All right.
Okay, I'll start my lecture.
Very
Uh,
good.
Dr. Ohata presented a very nice lecture, but it is very professional. So I'll talk about the more simple approach, anterior petals approach. So this approach was developed in 1985. And initially it was applied to basilar trunk aneurysm, but gradually indicated to the petroclival tumors. This is one uh, excellent example of a dumbbell-shaped trigeminal schwannoma extending into middle and posterior fossa. So it can be removed but only by this approach. So I will talk about this. First of all, I'll talk about the anatomy of the petrous apex. So the petrous apex is covered with tentorium, and the anterior part is separated by the cameral sinus. And it is connected with Gruber's ligament to the cleaves. So the under the Gruber's ligament, fifth nerve passing through, and between the tentorium and the Gruber's ligament, fourth nerve running. And the abducens nerve crosses just under it, and it running inside the inferior petrosal sinus. So this is the sagittal section. Pointer is not up here. So this is the sagittal section along the trigeminal nerve. So Meckel cave is very wide space. And it is the trigeminal nerve is compressed by the petrous apex superiorly. So by opening the Meckel cave, by cutting the Gruber's ligament and the removal of the petrous apex, you can mobilize the trigeminal nerve very easily. So the petrous apex has no organic structure. The posterior part include so auditory organs and facial nerve. However, the anterior part has no organs. So if you drill off this petrous apex, this part is very small, only 2 centimeters in diameter. And you must check the location of geniculate ganglion. It is located very superficially under the bone, only 1 or 2 millimeters just under. So do not resect this area. Dr. Ohata is a professional one, so he demonstrated. But I don't recommend to resect this area to preserve, not to injure the seventh nerve. And abducens, you must check the location of abducens nerve. It is just on the tip of the petrous apex. So do not resect the bone widely toward the cleaves. You may injure the abducens nerve. So next, I'll talk about the indication. So this is a CP angle meningioma, not a petroclival meningioma. But some neurosurgeon may say this is a petroclival meningioma, but it is not. It is enough for littoral sigmoid approach. So, and this is, it looks like petroclival meningioma, but it is not. It is a lower clival meningioma. So note the height of tumor attachment. The main attachment is lower than internal auditory meatus. So if you apply this anterior petrosal approach for this tumor, you cannot observe the lower half of the tumor. So it is indicated by the littoral sigmoid approach. So the indication is not the tumor size, but location of the tumor touch. Attachment superior and anterior to the internal auditory meatus. So this is one good example of this approach. So the tumor attachment is located anterior to the internal auditory meatus and superior to the meatus. And the tumor extending into the macular cave. So this is a good indication. And if you apply the littoral sigmoid approach for this tumor, the trigeminal nerve may be hidden by the tumor, and the seventh nerve, eighth nerve complex, and the petrosal vein are on the tumor. So you must mobilize those nerves and increasing the risk of injury to those nerves. So this is a surgical view by the anterior petrosal approach. So only the trigeminal nerve is on the tumor. You are not necessary to expose the facial nerve. And trigeminal nerve can be mobilized after resection of the pyramid. So, and the superior petrosal sinus can be preserved by detachment of the petrosal sinus more anteriorly. Dr. Ohata also mentioned about this. So the facial nerve is not exposed, and access to the macular cave is very easy by this approach. By the suboccipital root, the macular cave is the deepest point. However, by this approach, macular cave is most superficial part of the tumor. So by the anterior petrosal approach, no damage to the cerebellum, no damage to the temporal lobe, because this is an epidural approach. So this is the classification of so-called petroclival meningioma. So there are three types: upper clival, sphenoclival, and petroclival. So upper clival is has an attachment medial to the trigeminal nerve, and the sphenoclival have extension, tumor extension to the middle fossa. So both types are indicated for the anterior petrosal approach. However, for petroclival type, this tumor extended more posterior to the internal auditory mesh. So attachment is wider than this. So this is one example. Dr. Ohata mentioned so much. So I do not talk about this. So broad attachment extending posterior to the internal auditory mesh, it is indicated the combined petrosal approach. So next, I will talk about the surgical technique. This is the positioning. Head is positioned laterally, and the supine position, supine lateral position. So my voice is recorded. Dural approach is very important to spare venous complication. This is the positioning. The head is rotated laterally with the shoulder pad. The upper body is elevated 20 degrees. The anterior incision is straight and curved along the temporal line to expose temporal muscle. This is assistant view. The temporal fascia is exposed. The fascial flap is elevated from the muscle to use for closure. The temporal muscle is elevated from the skull and retracted anteriorly. This is a surgeon's view. Exposure of zygomatic arch is very important to create a craniotomy inferiorly. The craniotomy is made along the squamous suture with 3 buttholes. The size only 5 centimeters in diameter. The craniotomy must be made flush to base of the middle fossa. Okay, once again, so the temporal fascia is elevated from the muscle, and the muscle is retracted more anteriorly. And very important point is to expose the root of zygoma. It is a good landmark of this approach. And the size of craniotomy is almost the same to the squamous suture. So it is only 5 centimeters in diameter. And the bone resection just under the zygomatic root of zygoma is very important to access to the foramen spinosum. So, so this is a movie to access to the foramen spinosum. Foramen spinosum is the deepest point of the middle fossa. So the middle meningeal artery is coagulated now and detached. So this is the anatomy of GSPN, greater superficial petrosal nerve. It's running in the bone groove. And it is adherent to the outer layer of the dura. So initially I exposed by separate the dura, but sometimes I made injury to the GSPN. So the dura adherent to the nerve is cut only one layer. So periosteal layer of the dura is cut along the nerve. So like this. So this is GSPN. GSPN is left preserved by leaving the periosteal dura on the nerve. So this is a technique to preserve the greater superficial petrosal nerve. So periosteal dura is left on the GSPN and the pyramidal apex exposed. This is anatomy. The GSPN is the good landmark, lateral landmark of the petrous apex. And the arcuate eminence is a posterior landmark of the petrous apex. So the petrous apex is drilled off by two landmarks. So this is an example of, this is the GSPN, and this is the petrous apex, and this is the arcuate eminence. So drilling start to preserve arcuate eminence and the GSPN. GSPN here. So I sometimes use bone tooser. It is a very safe tool for to resect the small part of the bone. And this is after resection. You can find the dural bulging. It is a internal auditory mass. So, if you extend the bone resection more laterally, it may cause a lot of complication. Because if you extend the bone resection laterally, you will expose the geniculate ganglion, GG. GG is a geniculate ganglion. This is like a genu of the facial nerve. It looks like a genu. So by cutting the GSPN, you can expose this geniculate ganglion, but it is located very superficially. So very fine technique is necessary. So do not try to expose this area. And the cochlea is just under. So you may lose the cochlea. You may you may cause injury to the cochlea. So do not overdrill laterally by cutting GSPN. So it causes a risk of injury to facial nerve, cochlea, and more laterally, ICA and eustachian tube. So after this resection of the bone, the incision of the dura started from the middle fossa, number one middle fossa in T shape. And the next step is the opening of the posterior fossa dura, number two. And after this, the sinus, petrosal sinus is ligated. And after double ligation, number three, cut the tentorium. And please note the post nerve courses along the tentorial notch. So this is the example to cut. This is the middle fossa dura cut in T shape, and it is extended along the petrosal nerve, petrosal sinus. And this is the posterior fossa. This is the posterior fossa. And the sinus is ligated using, this is a very convenient tool named Maniceps. It is very easy to ligate the sinus with this Maniceps. And this is the fourth nerve crosses along the tentorium notch. Do not take care not to injury. And the next step is to open the metal cave. So just under, you may find the root of trigeminal nerve. And by cutting this area, this is the Gruber's ligament. Gruber's ligament must be cut by a small knife. So micro knife is very important to cut it. Only one centimeter anteriorly, you can observe the metal cave. You can make the trigeminal nerve free from the cave. And after this, you can mobilize the trigeminal nerve very easily. So this is the anatomy. And behind the trigeminal nerve, sometimes you can find the basilar trunk and the Ica junction. And this is one example of upper cribal meningioma, not a large one. And most of the petrocribal meningioma has tumor feeders from the tentorium. So on the way to cut the tentorium, you can coagulate the tumor feeders before tumor decompression. So I don't expose the facial nerve intentionally. So after cutting the feeding artery, gradually you can remove the tumor without bleeding. This detachment of the feeder is not possible by the sub-occipital route. So this is after removal of the tumor. Sometimes the petrosal vein is so on the tumor. So if you can confirm the petrosal vein, you must detach the superior petrosal sinus more anteriorly. So if the tumor extends into the metal cave, the removal is very easy by this approach. And this is the one example, very huge cribal meningioma. The tumor length was 6 centimeters. But please note, this tumor has a narrow attachment. So it is like a giant aneurysm with narrow neck. So the attachment can be covered by this approach. And the feeding artery, you can find the feeders inside the tumor. It is located within this approach. The surgical space is only 2 centimeters in diameter by this approach, but the working angle is 90 degrees. So do not fix your microscope observing through the keyhole. This is the keyhole surgery. So the technical step is to remove the tumor by internal tumor decompression. Marginal tumor margin is retracted toward the base. Then you can obtain enough space of sharp dissection between the tumor and the neurovascular structures. Compressed neurovascular structures may come back to the normal position by this technique. So no danger by retraction of the tumor. So this is after surgery. Even the tumor has the large one, but the attachment is localized. It can be removed by this approach. And this is the maximal size of the attachment by this approach. This tumor extending into the middle fossa and the metal cave. But the attachment is from the posterior clinoid to the just the middle of all the creeps. So it can be removed only by this approach. So this is after surgery. Not from the posterior fossa, but from the metal cave, it is removed. So please note, no abducens policy. This is a different case. The patient had a past history of operation by pre-sigmoid approach. However, only the part of the tumor was removed and transferred to my hospital, and I applied the same approach. However, I did not dare to remove the tumor totally because the tumor had adhesion to the brainstem, because this is the second operation. So radical dissection was depend on the adhesiveness to the brainstem and the invasion into the cavernous sinus. The rest of the tumor was treated by gamma knife after that, and the control. And I'll talk about some risk of the tumor with thick capsule. If you find the thick capsule on the tumor, around the tumor, it means that most of the neurovascular structures are in the capsule, severely adherent to the capsule. So do not try to remove the capsule itself. But intracapsular resection is necessary. Do not try to remove the thick capsule. It includes the ICA and the abducens nerve and so on. This patient was a medical doctor, but she could work after operation. And this is a different case, cystic tumor. It is a trigeminal schwannoma. And most of the neurosurgeons may choose a suboccipital route. However, in such a case, the facial nerve is compressed by the tumor posteriorly, so that by the suboccipital route, you may find the facial nerve on the tumor. So I tried to use this approach for this tumor. And the tumor was removed without observing the facial nerve. Facial nerve was left in the posterior fossa. And this is the trigeminal nerve, trigeminal schwannoma. Presented at the first of my lecture. So this patient was very young male, and the ataxia compressed by, the brainstem was compressed severely. So for the trigeminal schwannoma, I do not expose the temporal lobe, but simply I cut the periosteal dura and expose the tumor. Because the tumor is located in the lateral wall of the cavernous sinus, wrapped with inner layer. So inner layer is thickened by the tumor that separated the cavernous sinus from the tumor. So if you preserve this inner layer, you may not injure the abducens nerve and the carotid artery. You may not open the cavernous sinus. So please note that you can find the carotid artery and the cavernous sinus was preserved. And the brainstem came back to the normal configuration and no injury to the temporal lobe because this is a epidural approach. No abducens palsy. And in the last, I talk about the closure. I used a double layer using abdominal fat and the pericranial flap. Closure is very important to prevent CSF leakage. So the first step, I use the piece of abdominal fat placed on the pitos apex, already drilled off, and coated with fibrin glue. And this mass is covered with temporal fascia and sutured with the dura. It makes a complete closure. After the 2-layer closure, the incidence of CSF leakage tremendously decreased. So this is the advantage of anterior petrosal approach. Number one, no crossing to 7th to lower cranial nerves. So the risk of injury was very, very low. Number two, easy removal of middle fossa macular cave tumor. Middle fossa, posterior fossa, both sides can be opened. Number three, early control of feeding arteries. And number four, short operation time comparing the sigmoid approach, because the resection of the bone is limited and auditory organs are preserved. And what is the disadvantages of this approach? Number one, epidural venous bleeding in patient with sphenobasal vein. I'll talk about later. And number two, difficult learning and difficult performing because this is the keyhole technique is required. Keyhole technique must be learned before that. So I'll talk about the basal vein. In the common case, the sylvian vein drain into the cavernous sinus. This is a normal pattern. However, in 50% of the patient, the sylvian vein drained into the pterygoid plexus through foramen ovale. And in such a patient, the pericavernous sinus has a thick so venous plexus epidurally, not the subdurally. Epidurally, so epidural elevation may cause the severe venous bleeding in such a case, especially around the foramen, dissection around the foramen ovale. So in such a case, sometimes I use a subdural approach to the petrous apex, but very professional technique. And sometimes I use suboccipital route. So before surgery, please check the venous anomaly in the middle fossa. One anomaly is sphenobasal vein, and another uncommon anomaly is infratemporal vein. So tentorial vein is another one. So such a venous anomaly must be checked before surgery of the anterior petrosalpus. Thank you for your attention.
Thank you very much, Professor Kawase, for this illustration of the Kawase approach